Hi Raju. Today I can see that you have selected a paper of great relevance for both pediatric rheumatologists and general pediatrician, and it is covering HSP, so Hemlock-Schönlein purpura, now known as IgA vasculitis.
Michael, just for the record, Schonlein first described the condition in 1837, and Henoch was Schonlein's student who reported a series and got the pole position with the eponym 38 years later. I wonder how his teacher felt if he was alive then.
Raju, all is fair in love, war, and probably publishing, but now gets over on IgA vasculitis.
True, this short review is actually a perfect quick read on the current diagnosis and management strategies for IgA vasculitis. But I wish they had restricted to nephritis alone, as the title suggested. Nonetheless, this commonest vasculitis of childhood needs all the attention this article has given.
Absolutely. This is a self-limiting disease, but renal involvement causes a lot of morbidity and mortality, and therefore it's a most important prognostic factor. So it is seen in 20 to 60% of the children with IgA vasculitis, quite a variation. But fortunately, chronic renal failure is much less frequent and reported in only 1 to 15% of cases. So this wide variation is probably due to the type of center. If you are a very specialized center, you probably see the most severe cases, and then the percentage is much higher.
Another important fact I learned, Michael, was that the highest incidence of IgA vasculitis and IgA vasculitis associated nephritis is seen in East Asia. And this struck me as quite similar to Kawasaki disease. And I was just wondering whether this is coincidence or what.
Very interesting, Raju. And considering this, do you see many cases in India?
Definitely, Michael. I see quite a lot of IgA vasculitis. I would be seeing at least 3 or 4 cases a month. But I have noticed one thing, they tend to cluster. Like approximately in the last 2 months, I saw all of them coming together. And then for a few months, there will be nothing at all.
So, when we look at renal involvement, then we can have urinary abnormalities, including hematuria and or proteinuria, and we can go to nephritic or nephrotic syndrome. Mild pathologic urine findings are the commonest finding and are seen within 6 months of onset.
So, this fact that you just mentioned, Michael, this is a very vital clinical point since renal features may emerge or be missed for long after the more dramatic aspects of the disease have vanished. Thus, the reason to measure blood pressure and monitor renal involvement using eGFR and urinalysis that includes assessment of hematuria and proteinuria with urine protein and urine creatinine ratio in an early morning urine sample for up to 6 months. I repeat, up to 6 months after the first symptoms are absolutely necessary. But, Michael, what about the kidney biopsy?
So this is an important point since we don't like to do invasive examination in our patients. And when we go to the SHARE guidelines, so there are relative and absolute indications for kidney biopsy. So the absolute indications are based upon the degree and duration of proteinuria and the presence of impaired GFR. And the commonest classification used to analyze histopathology is the ISKDC classification, while a few others also exist. We should remember that the SHARE guidelines use this ISKDC classification also to plan treatment.
However, Michael, this ISKDC classification does have some limitations in that it focuses mainly on glomerular involvement and neglects vascular and tubular interstitial changes. Since you mentioned treatment planning, let me shift focus. Broadly, there are two recommendations and consensus statements: the KD-GO guidelines of 2012 for adults and children, and the SHARE recommendations of 2019, which focus only on the pediatric age group. A close look at the KD-GO suggests that they have divided treatment into three categories of changes while offering no suggestions on patients with isolated hematuria. The SHARE recommendations classify children into four categories, considering the degree of proteinuria, its duration, the eGFR, and the percentage of crescents on kidney biopsy while deciding treatment. Second line drugs in the mild varieties consist of azathioprine or mycophenolate, while these drugs are also used as follow on medication after cyclophosphamide in the more severe cases. Michael, what's on the horizon? Anything new?
So there is some research on development of novel biomarkers for IgA vasculitis, and the list of tongue-twisting molecules is endless. And about biomarkers, I hear about biomarkers since I'm doing pediatric rheumatologist, but unfortunately, there is not a lot that came out since then. So non-invasive confirmation of nephritis is still pending, but an increased serum level of IgA1 is promising biomarker for IgA vasculitis. And therapeutic option are directed against on the production of GD IgA1 include oral budesonide, which can target pious patches in the ileum that are thought to be the origin of the production of this molecule. So another option targeting the similar mechanism is a proteasome inhibitor, bortezomib, which acts as a plasma cell depleting agent affecting the production of IgG autoantibodies.
That's interesting, Michael. There are so many NIBs and MABs in various studies, but imagine budesonide and its checkered or very unique history starting as an asthma medication and then ending up as a potential for IgA vasculitis. That will be a winner idea if it succeeds. Sweet, safe, and simple.
Yes, you are right, Raju. We always look for something very fancy, but simple medication are probably the best for our patient. Thank you very much, and see you next week.